Very good morning. This is Dr. Rupesh Kaushik, cardiologist, and I'll be talking about conduction abnormalities today. I'll show you a clinical case. This is first to demonstrate how a normal ECG or normal conduction look like. This is, you can see a P wave. You can see the narrow P wave. This one is P and this is QRS complex. This is P and this is QRS. So every P wave is followed by a QRS complex. You can see there is a P wave is followed by QRS complex and then a T wave. P wave indicates atrial depolarization, and this PR interval depicts the time for the impulse to travel from atria to the ventricles through his bundle system, and this QRS, Q, R and S depicts ventricular depolarization, and T wave indicates ventricular repolarization. So we can see that every atrial depolarization or atrial contraction is followed by travel of the impulse to the ventricle, followed by ventricular contraction or ventricular depolarization, followed by relaxation of the ventricular muscle. So every time the impulse starts from sinus node, it travels through his Purkinje system, goes to ventricle and causes a ventricular contraction or ventricular depolarization, followed by relaxation. So this is the next impulse. So in this ECG, normal ECG, we can see that every P wave or atrial depolarization is followed by a ventricular contraction or depolarization, followed by relaxation. So this is normal conduction system. We can see that the interval of the PR is also normal. It means that the time taken for the impulse to travel from atria to ventricle is also normal. What is the normal PR? PR is 200 milliseconds or less. We can see the smaller squares in the ECG graph indicates 40 milliseconds. So one big square contains 5 small squares, means 40 into 5, that is 200 milliseconds. So if your PR interval, that is if your starting point to this point is less than 5 small squares, this is normal conduction times for the atrial impulse to reach ventricle. So this is a normal conduction times for the atrial impulse to reach ventricle. So now I'll come to our case which we saw today morning. This is a case presented with shortness of breath in the emergency and heart rate was recorded low. So looking at this ECG, we can go with this. You can see there's a P wave, but there's no QRS. You can see there is a P wave, but no QRS. Again P wave, no QRS. Again, this is a P wave, but not followed by a QRS. Here also we saw a QRS, Q, R and S, and this is a T wave. So here also we can see a lot of P waves which are not followed by QRS. So these atrial contractions are not reaching ventricle, and this ventricle contraction, that is Q, R and S, is wide, means it is originating from the ventricles. So wider QRS escape and very low heart rate indicates ventricular escape rhythm, not the escape from the his bundle Purkinje system. So look at this again. We can see if we try to follow our P waves, we can just mark our P waves. We can identify all our P waves. You look at this P wave marking this point, P wave marking here, P wave here. So if we march our paper through this, we can identify all our P waves. So you can see that one P wave is buried at this point in this QRS, one P wave is buried in this T, and when we see this is a P wave, we can identify P waves. One P wave is buried in the T wave, and when we keep marching, you can see that there is P wave here. So now looking at this, one P wave is buried at this point, one P wave is buried at this point. Looking at this, you find this P wave is here and one P wave is here. So there are a lot more P waves for every QRS. So when there are a lot more P wave for every QRS, you have conduction system which is getting blocked. So we have P waves, and when there is no relation between when the PR interval is not constant, it keeps on changing, and there is no relation between P and QRS contractions, we say it is a complete heart block. So this patient is a case of complete heart block or third degree AV block. Third degree AV block. And how do we calculate the heart rate? We calculate the heart rate by larger squares. You can see 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, almost 14 squares. So when you try to divide 300 by 14 or bigger squares, the heart rate comes around 21. or you can do the other way around, like you can count the smaller squares and divide 1500 by smaller squares. You will get the heart rate. So this patient had heart rate of 21, and the patient was in cardiogenic shock and complete and congestive heart failure. Patient was intubated and brought to the cath lab. In cath lab, but we did temporary pacing. This is a temporary pacemaker wire. We have gone through the inferior vena cava. This is the right atrium and this is right ventricle. We have inserted the wire in the right ventricle. So after we have placed the wire, we fixed it there, and then we recorded the ECG. ECG was recorded after setting the heart rate at 80 beats per minute. We usually set the heart rate at 60, but if the patient is in cardiogenic shock, we want heart rate to be slightly higher. So what these spikes, you can see these spikes are the pacing spikes. You can see these spikes. These are pacing spikes, and the heart rate is, you can see the heart rate. The gap between these two spikes is 3.5 squares. That is, heart rate is around 83. If you calculate by formula 300 by 3.5, so roughly heart rate is 83. So this is how we do pacing. As I said, that this QRS is wide. The QRS is wide because we are pacing the right ventricle muscle. When the conduction goes through muscle, it takes longer time, so the QRS will be wider. When the conduction in the normal system takes through his Purkinje system, the QRS will be narrower. So when you have a narrow QRS, means the conduction is through the normal his Purkinje system. When you have a wider QRS, you know that the pacing is through the muscle bundle, and muscle bundle takes longer time to depolarize and takes conduction longer time to travel across heart. So you will have a longer conduction time and wider QRS. And escape also we can see, if the escape is wider, if you see the escape, QRS escape is wider and the heart rate is low, you don't get escape through the Purkinje. And these are the patients who are the most sick patient, because if the escape is through his bundle, the QRS will be narrower and the heart rate will be more than 40. So when there is a complete heart block, there can be two kinds of escape. One is escape through his Purkinje system, when the escape beat comes from near to his bundle and it conducts through his Purkinje system. These patients will have a heart rate around 40-45. They are stable patients. But this kind of patient which I have shown right now, they don't get that escape. They are in the most difficult situation. His Purkinje system is also not taking up after complete heart block. Then their ventricle starts giving escape beats, and these escape beats are unstable, wide, and they are the patient who need urgent, immediate and emergency temporary pacemaker support. Thank you so much. We'll come back with newer clinical cases. Thank you.